we should always be able to have these real conversations, because we're not going to change anything by, sugarcoating what's going on in our communities.
I think the lived experience can actually help to inform diagnoses, treatment, and the relationships that we form with all of those on our medical teams.
Parents have a PhD in life experience, and we're able to bring that to the clinician, and they respect that. And they're like, oh, you can talk my language. And we have these real, authentic conversations so they get somewhere.
When we designed this seminar series, we thought it was really important to create a supportive forum and a safe space to have these critical discussions that ultimately will help to improve clinical care. In order to do this, we have partnered with families for this series.
Welcome, everybody. My name is Rishi Agarwal.
My name is Kara Coleman, and I am the Director of Public Policy and Advocacy at Family Voices.
My name is Eyal Cohen. I'm a pediatrician at the Hospital for Sick Children in Toronto.
My name is Kate Robinson. I'm your moderator, and I'm a project director with Family Voices. I'm very excited to be here today. About 7.5 years ago, I had a 2.5-year-old and had a child who was born medically complex. And in the past 7.5 years, I've spent many months in pediatric hospitals and had the very good fortune to experience real clinical family partnership.
And so we've had our share of ins and outs of the NICU and the PICU and doctors and specialists, and we really appreciate taking a look at this view and lens of not only from the doctor's perspective but from the family's perspective.
And if we want to improve those outcomes and we want to lower utilization, it's not enough just to create financing mechanisms and complex care programs. We need to improve the standards of care that are delivered to our patients.
So my main takeaway and what I've all learned from it is, while I understand, golden standard treatment is there for a reason, it works for most folks. It's important to listen to the people that know their bodies really well and who are, in tune with it because they've lived with it their whole life. And it's always good to be a little bit lenient where you can in treatment or just your ways of thinking.
So sometimes we don't connect also with what our kids are saying. So I think it's important for all of us to listen, is where I'm trying to get to, is we all need to listen to the patient.
Our youngest son Truman was born at 26 weeks gestation, so micro-preemie.
So I'm going to focus in on my son. He is 15 now. He has a diagnosis of Down syndrome.
I have a son, Joshua, who is medically complex. We actually just got back from a recent week in the ICU this week.
Our son, Sean, was born with cystic fibrosis. He's 20 years old.
I am, as you heard, the mom of 3. My oldest, Andrew, was born only 5 weeks early, but we found out in the middle of our pregnancy that he had stopped moving, and so therefore developed a lot of medical complex issues.
And I am the mother of Elias, who is a 9-year-old 4th grader now. And I'm also the sister of Brenda Liss, and she is 32 years old now.
Yeah, I'm Maureen, and I'm the mother of George. So George has a spastic quadriplegia from an anoxic brain injury when he was 12 years old.
I'm Kate. I live outside of Austin, Texas with my husband and my 2 kids. And then I have a 7-year-old named Rowan. And Rowan, Kate, you did an excellent job. It's hard to say. She has a rare genetic disorder called recessive dystrophic epidermolysis bullosa, and it took me a long time to be able to say that properly.
My children do amaze me every day, and part of that is because they do have so much to overcome.
I just want to reflect on the relationship piece between provider and family. I think initiating, building, and keeping relationship in this lifelong, because we're in it for the long haul. We have children, then we have teens, then we have adults.
I wish people had more of a relationship with their doctor like I have with mine, because I think that's the key. For me with tone management, it's not necessarily what drugs are out there, it's what conversation needs to be had to do the risks and benefits.
Most of CME, continuing medical education, is focused around knowledge. That's good, that's important. Knowledge saves lives. But communication, that's what I would focus on.
The pharmacists, in my experience, I'm so reliant on the caregivers to be able to provide their story, provide me their history. We have to start thinking about ways we can reduce polypharmacy in many cases. And that really relies upon the parents being involved.
And I'm really interested, before we go to wrap up, if you have any thoughts on how we as providers can be mindful of the parent experience and how much of what we ask is actually an ask of parents and family caregivers.
So parents are the hands, feet, eyes, every other piece that we need in the home and other environments for this kiddo. We have to really work on what you need us to work on. And that means listening and taking the time to listen.
Because you can't help your children if your bucket is just overflowing with your own stuff. You have to be able to triage that and mitigate it. And so for me, that's a big one, is making sure as clinicians or therapists or anyone that's touch pointing with a family that has high needs, just asking every so often, how are you? And being authentic and really meeting it.
And that's why in my mind, I divide the family in two groups, like rookies versus veterans. Like you're definitely a veteran here, and which means that you've gone through a lot.
I think the other part that maybe is helpful for families too is we spend a lot of time talking about what brings sadness and what brings anxiety, and taking some time as families to think about what brings joy. So when is their child happy? When do they feel loved? When do they feel comforted? And continuing to build on that to offset some of that anxiety and sadness as well. So as much as we want to assess those things to help prevent them, can we also create a space where they get to do the things that they enjoy, that they like, that bring them happiness?
One of the areas of research is that we're lumping all the patients with complex medical needs or even with neurologic impairment together. And I don't think everyone has the same physiology and as such will not respond to the same interventions the same way.
Knowing that kids are dynamic and it might take a little bit of some creativity, but that's where the individualization comes through.
I think I would just leave you with the idea that we can make a difference.
And I appreciate everyone saying how real this conversation was. I feel it was very authentic. And thank you, Catherine. Thank you, Ayel. Thank you, Rishi. And of course, thank you, Antonio, Leslie, and Tina. I appreciate this so much. And it was fantastic use of the afternoon.
I'm only delighted that you've done my job for me. And I just have to say thank you very much to everybody